Wrap up on breast cancer. What did you learn? Did you go and screen? What was your experience? That's right, a pink October. Wrap up with me. Stick and stay. Let's help each other.
Joy 99.7 FM.
Ed Sheeran, Fuse ODG, and my man Mugiz.
Yeah, Joy 99.7. Yeah, you help me see when I've been blind. Even when I'm feeling paralyzed. You help me seek so I can find happiness on a rainy day. One man ya do, one man ya do, mama when you do. If you want something for your body, can't every problem so move. Must it be something for somebody? So we need to cry, help your brother in every way. Yeah, one joy, yeah, one. So me when I want me, yeah, they want me why, yeah, they want me why. Who me na messy my chest, she up for me a brunch, yeah, they want me why. Who me na messy me she up for me na me, yeah, they want me why. Who me na messy me she up for me.
Oh yeah, in Afenya, you can jam.
Yeah, they want me why. Joy 99.7. I am calling, so give me your hand. You want to think that's my brother? When I request for water, you forgive me your champagne. Things are not going to go. Only God will stop it. As the sun they shine away, the wind they blow things be all day. And if I owe you sometimes, the ram my brother will come. Yeah, Joy 99.
Do love Mugiz, huh? About 2Bs. As for Ed Sheeran, I'm convinced he's a Ghanaian. Welcome to Ultimate Health. Hey, and many thanks to those who patronize the old school pub chain at the Gold Coast. What a blast, huh?
Another OPK classic.
Oh yeah, in Afienya. Oh yeah, in Gold Coast. But anyway, we've had a whole month of breast cancer awareness, education. We've gone through the different management options, intervention options. I'm joined virtually by Dr. Anita Osofrie, resident oncologist with the International Maritime Hospital. We're going to do a wrap-up. What did you learn during the whole month? Are we making any impact? Did you report for screening? What was your experience? WhatsApp is 055 11 11 997. We're live on Facebook and YouTube. Ultimate Health, your ultimate guide to healthy living. So we're going to do a wrap-up. Remember the emphasis. We hit on it. Early detection, screening, critical, non-negotiable. Let me say good afternoon to Dr. Anita Owusu Efrie. Doc, good afternoon. Hello, Doc. Okay, looks like I've... Let me see if Abeku can reconnect. We're doing a wrap up on our breast cancer month, Pink October. We're in November now. And you can share with us what's up, huh? What did you learn? What can you remember? Any new insights when it comes to breast cancer, risk factors? How to lower your risk? How to screen? And then the different outcomes of screening, and then the steps that follow, and the different types of intervention, etc. You can share with us 055 11 11 997 Ultimate Health on Joy 99.7 FM. We'll have Dr. Anita Efriye, she's a resident oncologist, to take us through the basics, the fundamentals. Yeah, trying to reconnect with her now, but you can fire off your WhatsApp messages. So, Doc Anita, you're welcome. If you can unmute. Hello? Okay, looks like I've lost her again. Just... let me swing back to my WhatsApp and see if she's not on yet. Let me see what's in my box. Did you go and screen?
You know he's
Joy 99.7 FM.
Did you take advantage of the free screening available at various facilities? How did it go? Did you confront your fears? Did you get more education? Okay, on WhatsApp, this one says, let me just see what I have on WhatsApp. Let's see how we sort out this technical challenge. Get our doctor, our oncologist back online. So I want to know from you, my listeners, did you screen at all? Did you follow up on all the education, the awareness? Or was it stubborn academy as usual?
Joy 99.7 FM.
We're doing a wrap up on our Pink October month. What did you learn? What did you remember? What action? And more importantly, what action did you take? If you want to call us, 030-221-6541. 030-221-6541. Let's see what your feedback is. Especially, particularly, if you went forward for screening.
like, seriously?
Joy 99.7 FM.
Okay, I had Dr. Anita Uswefriye on the phone lines. Doc, good afternoon.
Good afternoon.
Right, you're battling with the connection,
Yeah.
eh?
Sorry.
Right, how are you doing?
I'm good, yourself.
We're well, we're fine. We've done a concentrated, intensive month of breast cancer awareness, education, and so on and so forth. I wanted to find out from you, from the facility end, from a specialist provider perspective, how has the month of October, the pink month, been for you at IMA?
Okay, so IMA has been good. the attendance has been great for the month of October, to the extent that we had to open the 10th of October and extend it to the first week in November. So we ended it officially yesterday.
Wow.
So
So
the attendance has been great so far.
we had a good response. When you say
Yes.
attendance has been great, one of my key indicators, what kind of, just roughly, I know you're now preparing and cleaning your data for the month, but what
Yes.
kind of numbers, what's the profile age-wise of typically, I mean, I'm sure it's typically or primarily women. What can you say about the people you were seeing?
Okay. So we were getting over, I think I was talking to the gentleman in the data. Yes. What saying? Last year we got about 1,000 over, and it looks like it's still more this year. Yeah.
You're breaking a bit, but last year you had about 1,000 and over women responding in the month of October, and this year it's a bit more than that.
Yes.
Okay, and what can you give us a profile, maybe a rough profile? Are you seeing younger women? Are you seeing typically the same age ranges, and so on?
For the profile, it will be a bit difficult because the data hasn't been put together. But for personally, most of the people I was seeing coming back with their mammogram reports were mostly people 40 and over.
Right, 40 and over. Okay, and these are people who had gone through screening and had done the mammogram as well.
Yes.
Okay. Is this any different, just from your experience and perspective again, from what you'd seen in previous years?
Okay, so usually it gets to a point people have something with the mammogram, then you ask them to follow up with the doctor, but sometimes some don't report immediately. But I think for what I observed, most of them were able to wait for a doctor to go through the report with them, the necessary follow up and discuss with them.
Okay. Right. Folks, if you've just joined us, 60 minutes past the hour of 2, the program is Ultimate Health on Joy 99.7
Joy
FM.
99.7 FM.
We're doing a wrap-up of our Pink October month. We did an intensive, concentrated month of breast cancer awareness and education in strong partnership with the International Maritime Hospital. I have Dr. Anita Owusu-Afriyie. She's a resident oncologist with the IMA Hospital. We're just looking at the response. And I want from you, my listeners, share with me on WhatsApp 055 11 11 997, or when you call us when I activate the phone lines. Did you actually take advantage of the free screening and other things and packages offered by various medical facilities? Did you get yourself checked? What was your experience? Did you manage to confront some of your fears, dispel some of the myths? And what's been your experience? You can share with us on WhatsApp 055 11 11 997. And when you do call us, we're live on Facebook and YouTube as well. I'm going through some of the basics with Dr. Owusu-Afriyie. So, Doc, we had women responding, at least with specific regard to IMA, and many of them followed up. Typically, women tend to default or not adhere or comply when there's something found in their screening and they're asked to do further investigations. You're suggesting that this year there was perhaps some slight improvement on follow-up.
Observation, what happens is, so beginning the program, and we just after then they program report, although.
Okay, it looks like we're losing you, Doc. So I'm going to ask Abiyaku to reconnect. Listeners, we're trying to get feedback and reconnect with Dr. Owusu-Afriyie. We're getting some indication that the numbers of women responding to our intensive breast cancer education and awareness are quite positive and positive or probably higher than what we saw last year. and we're going through some of the basics. And I want you to share with me by WhatsApp or on the phone lines if you were able to take advantage of the various packages and products available across the country at different health facilities. Yes, Doc, are you back?
Yes, please.
Okay, so I was talking about default and then you were responding.
Yes. So I was saying that most of the times after the scan and the mammogram, what happens is you see them coming back later, showing up with reports that, oh, I came for screening, this was the mammogram, I just wanted to look at it. But this time around, people were willing to wait. Can you wait for the doctor to go through the report with you? And they are willing to wait. Yes.
Okay, that sounds good. So we got a kind of a good response, and we'll be looking forward to the actual cleaned up data. Oye Nafienya says it was nice to meet you in person. Welcome to my home. Yeah, Ofenya. I said Ofenya. Oh yeah, hey, you were jamming yesterday, all in the interest of breast cancer and raising funds, right? That was great to see you. I'd love to know if you did screen as well in response to our education. So Doc, coming back, we learned a lot of stuff over the months. We engaged with each of you, radiologists, radiotherapists, surgeon, and then of course you, the oncologist. But we did do a bit of stuff on risk factors, and you educated us on those that were modifiable and those that were not modifiable. Can we just quickly go over that for breast cancer risk factors?
Okay, all right. So just a quick one. I spoke about the fact that some of the risk factors, as you mentioned, are not modifiable. You can't do anything about them by default. You have it. Then you have those that you can do something about. So those ones are the modifiable risk factors. So when we talk about the non-modifiable, we have our age. So first you have an advanced age, you are growing, you can't do anything about it. So first you are also a woman. So, breast cancer happens in both women, but it's more common in women.
That's right.
So far as you are a woman, you also have the non-modifiable risk. Then we have early menarche. So menarche is like your first menstruation. So if you are menstruating less than 15 years, or if your menopause is at 55 years, then that's a risk, a non-modifiable one. Okay. Reason being that the breast cells are constantly exposed to the hormone called estrogen. Then we have those that have the genetic mutation, which unfortunately in Ghana, only few places run those tests. So we have those tests, BRCA1 and BRCA2 genetic mutation. Okay. So that one also puts you at risk. Right. Then with the modifiable ones, we have increased alcohol intake. We have history of combined oral contraceptives. So people who mostly are always taking oral contraceptives, combined oral contraceptives, the breast cells are constantly exposed to estrogen. Then we have nulliparous women who have never given birth before, and those who also give birth at a late greater than 55 years. Okay. All those things also put you at a reason being that the hormone estrogen, the breast cells are constantly also exposed to the hormone estrogen. Then you have those that they've never breastfed their children. So ideally, to breastfeed for a year or over, it gives protection as well. So those who don't breastfeed their children also put you at risk. Yes. Okay. So these are the common ones.
Right. So if you haven't given birth or you give birth late, that's one. If you start your menses early, that you have an early menarche, your first period, that's another marker. If you have your menopause late, that's another marker. Alcohol use, weight or obesity, and many other modifiable risk factors. Your age, your genetic makeup, and so on and so forth are not modifiable. The fact that you're a woman, even though it does occur in men, very rare, but it does occur in men. So the fact that you're a woman also heightens your risk. Doc, can we quickly talk about some quick signs and symptoms, and then we'll go into a bit more detail?
All right. So usually, as we went through Pink October, most of the people were having lumps, which they didn't know. So you feel a lump in your breast. Others will have the skin changes. So we have the dimpling of the skin, looking like that of an orange peel, which we mostly call the odorant. Then others will come with some reddening around the nipple or flaking skin around the nipple. Some too will come with nipple retraction. So their nipples are mostly sticking out. Then suddenly they see that the nipple is pulling it. It's not normal. We have people who are born with delta. So if you have that, please don't conclude I said you have signs of breast cancer. No.
Okay.
Those who have that, when you suddenly also see your breast also the nipples sticking out, then that's like opposite of what you had since growing up. So you just have to get a check. Yeah. Then we have people that come with discharge from the nipple. Commonly, it's bloody discharge, but we have others with other kinds of discharge, cream discharge, milky discharge. It doesn't mean you have breast cancer, no. The fact you're having abnormal nipple discharge, you are not a breastfeeding mother, please come and get. Then some also get ulceration. Ulceration is like the sore, any part of the breast. When you see anything of that, kindly get to the hospital for it to be.
Okay, right. 26 minutes past the hour of 2 on Joy 99.7 FM. The program is Ultimate Health, your ultimate guide to healthy living with me, Nortey by Nature. I'm speaking with resident oncologist at the International Maritime Hospital, Dr. Anita Owusu-Afriyie. We're doing a wrap-up on our Pink October month. We want to refresh all the things you learned, all the things you became aware of, new insights, things that you didn't understand. We engaged the radiologist, we engaged the clinical radiotherapist, we engaged the surgeon, and we engaged Dr. Anita Owusu-Afriyie herself, the oncologist. It's a multidisciplinary team that will handle you. We also spoke with the pharmacist about the medications that are used to treat and manage breast cancer. If you have any questions, concerns, experiences, WhatsApp is 055 11 11 997. We're live on Facebook and YouTube, and we'll shortly activate the phone lines. This one is from Mauli in Oda, or Mauli Oda. It says, I'd like to know if breast size is a risk factor for breast cancer. Good afternoon. Doc, any response to that? Breast size?
No. So whether you have small breasts, you have big breasts, it's not a risk factor. No, funny enough, we have patients that come in that they notice their breast size was becoming big. But because they've always admired big breasts, they ignore it. And later we investigate and find out that there was actually something going on. So breast size is not a factor, please. Just that if at any point you have a small breast, you notice that the breast is becoming big, please report to the hospital. I always say that we have one breast bigger than one for women. So make sure you know your body. You stand in a mirror, you know that, okay, my left breast is bigger than my right breast. So if I take one, you notice your right breast becoming bigger, then you should be worried.
Okay, right. So breast size is not an indicator, though she mentions that some women notice a change in the size of their breasts, and because they are looking for larger breasts, they may ignore it, all right? But that in itself or independently is not an indicator when it comes to breast cancer. Okay, you can send your questions 055 11 11 997. That's WhatsApp. We're live on Facebook and YouTube. The program is Ultimate Health. We're doing a wrap up on our Pink October month with resident oncologist Dr. Anita Oswefrie. She's at the International Maritime Hospital. We're also keenly interested in whether you proceeded, you heeded, you complied, and had yourself screened, and if anything was found, whether you followed and complied with the requested or indicated follow-up investigations. You can share with us kindly on WhatsApp 055 11 11 997, or when we activate the phone lines, you can join us with that. So, Doc, let me ask this: what about women who, came for screening? If nothing was wrong or nothing indicative was found, what is the communication they should have received?
All right. So if you come with your ultrasound report or the mammogram report and there's actually nothing, they are benign change or they are not. So benign means non-cancerous issues in the brain. So we give you a yearly follow-up. But if there was something, then it's recommendation. So sometimes you will need 6 months follow-up. Other times, a biopsy has to be taken immediately.
Okay. Right. So you'll be given some recommendations as to the frequency and the intervals of your follow-up screening.
Exactly.
Right? Something may have been found, but it may have been determined to be non-cancerous.
Exactly.
And this should be given in clear, unambiguous communication to the patient, to the woman or the man, right?
Yes. Yes.
Okay. So is this something you receive after some time, or would you receive that on site at screening?
All right. So what happens is we we do the clinical breast exam. We let you do the ultrasound if it's below 40 years, above 40, you do the mammogram. Then you come back to the screening room with a report. So we look at it. If they are non-cancerous, as I said, then we educate you on the yearly follow-up. But sometimes they saw something which they are not too sure. So you need a 6-month follow-up. We tell you that immediately. We don't let you go because, the anxiety alone, patients have come, done reported, then you tell a person to come back later. So we do that immediately. We tell you how you should follow up, whether yearly follow-up or 6-month follow-up.
Okay.
That's what I was saying, that this year the response has been good. People, we tell them to wait to see the doctor about the reports, and they sat down and waited. At that time, if someone just leaving, then they'll come showing up the report.
Okay. Yeah. Right, Doc, one of the things I want to hit on or get more clarity on, you said after screening, there is a report that is provided.
Yes, please.
Is it possible that somebody can come for screening at a facility, not necessarily IMA, but receive no report or receive only a verbal feedback? When you say report, is it something that is printed out that you get a copy of? Can you just clarify that?
All right. So usually the report is something that has been written out detailed by the radiologist. So the mammogram, I said, we have lots of things we look out for, and all that will be written by the radiologist. Okay. We have this classification called the BIRAD classification.
Right.
So the radiologist will write, okay, it's BIRAD 1, BIRAD 2, BIRAD 3, like that, up to 6. So these things cannot be interpreted by the patient unless maybe the patient is experienced. So we take it, explain to the patient. So there's actually a detailed report, which we even recommend you, the patient, you pick well. So that if at this point in time, you find yourself anywhere, and you are telling a clinician that, I did a program 6 months ago, I was asked to do a follow-up after 6 months, that report is there, or the first there.
Right.
or a comparison.
So,
by
Doc,
the clinic.
can you speak to these situations where maybe churches, organization, employers organize screening exercises and people go through, they claim they get a verbal feedback and they're quite happy and they go away, satisfied. You're suggesting that any meaningful screening should give something of a substantive formal report and the follow-up steps required.
All right. So most of the screening in churches at the marketplaces, we do the clinical breast exam only.
Okay. Right.
But if anything is picked up, we recommend you go and a mammogram, a nearby facility, or a scan, a nearby facility. Just that, unfortunately, the places, there's no active follow-up. Although you tell the person will choose whether go or not. So you are not challenged with those places. So you hear someone telling that I did screening last year and they told me everything was fine.
Right.
Mostly you probe further and you realize that the person was even asked to do a follow-up scan or mammogram and the person didn't do it. So we don't just rely on the verbal one. Just because it's outside the market, the church, the scan and mammogram is done, but we always have to go to a hospital for it to be done, especially if we pick up something that we are not sure.
Okay. Right, great stuff. 35 minutes past the hour of 2 on Joy 99.7 FM, Ultimate Health, your ultimate guide to healthy living. We're doing a wrap-up, a mop-up of the Pink October intensive, aggressive, concentrated education we did on breast cancer. We want you, we want you to share with us your experiences. Did you go for screening? Did you follow up? What was your experience? Any questions you have? Still outstanding. We want to be able to address them and answer them with the kind courtesy and input of Dr. Anita Efriye of the International Maritime Hospital. This one says, good afternoon, Nortey. Please, is it true that exposure to the mammogram leads to or can cause breast cancer? This is Senam in Lashibi. Doc, hang on to that. Let me read a couple more. I did see Dede typing. Good. She says, the mammogram is kind of painful. Therefore, most women kind of shy away. Is there a better way of making it less painful or more comfortable? This is Dede in Maryland. Dede, you're welcome. Thanks for bearing with our technical challenges. So, Doc, the first one is a concern that the mammogram itself may cause breast cancer. This is from Senam. And then Dede in Maryland shares and asks, is there any better imaging technique than the mammogram, which is less painful, or should I say more comfortable?
All right. So the mammogram is X-ray radiation, but there's a limit. There's little exposure. It's not an exposure that is going to put you at risk of causing cancer. No.
Okay.
We have very high doses of radiation that are there. Other sectors give a lot of radiation, but mammogram is not.
So the mammogram is safe. The mammogram cannot cause breast cancer. Is that what you're saying? Right.
No.
Okay. And then yeah, go ahead.
The second question. So I think in my discussion with Joy during the 10th October,
That's right.
I kept stressing on the fact that the mammogram should be done ideally 7 days after menses, because around that time the breast is less painful, less lumpy, and we get to examine it. So I would also increase the day to check the time she does the mammogram.
Okay.
Exactly. Look at for the appropriate time, because if around the menstrual period or before your menses, you go through something.
Right. So the timing of the mammogram should be at least 7 days or more after.
That's ideal.
Ideal.
Yes.
Okay. Is there any reason why a facility or should I say a radiologist or anybody else would conduct a mammogram on a woman who doesn't meet these criteria?
So unless there are patients that come in they tell you they're having a bloody discharge, and looking at the time of their cycle, 7 days will be like maybe 2 weeks away.
Okay.
You expect such a woman to go and sleep over it for 2 weeks. So in instances like that, we suggest you that you go ahead with the mammogram, which most patients are actually okay with it, just to count their.
Okay. Right. Phone lines active now 030-221-6541 030-221-6541. Ultimate Health on Joy 99.7 FM. We're trying to do a wrap up on our Pink October breast cancer awareness. Remember, I kept on emphasizing every year, annually, 4,000 plus Ghanaian women are diagnosed with breast cancer. Sadly, every year, again, annually, we lose about half of those women, right? We're emphasizing early detection so that the condition is picked up, if it's there at all, in its earliest stages where it's more manageable and more, should I say, amenable to effective treatment modalities, which we've discussed on this program. If you have any questions, concerns about any of the treatment modalities, we'll take them on today and deal with your experiences as well when you went for screening. I see some of you typing seriously there. Phone line is active now, 030-221-6541. Ultimate Health on Joy 99.7 FM. We're doing a breast cancer wrap-up. Right. So, Doc, that tells us what happens if there's nothing wrong. You'll be giving some recommendations for follow-up and an indication of the intervals at which you should be screened. Now, if something positive is found, how is this communicated and what are the kinds of follow-up steps that a woman should expect?
All right. So, I spoke about the virus communication after you done the mammogram. So if you are getting something like virus 4, it's highly suspicious of malignancy. Malignancy is cancer. So what we do is we tell you about what was found from the report and the need for the biopsy. It's not all the time that it will come out as cancer. Okay. But immediately that suggestion has been made by the radiologist. It's important we do a follow-up as soon as possible. And the feedback has been good so far. Looking at Pink October, anybody that we saw in it, they went ahead with biopsy.
Okay. So, just going back again for the benefit of our listeners, again, let me say phone lines are active, 030-221-6541. You can call and speak to Dr. Anita Osuefriye, oncologist with the IMA Hospital. Going back to the report that I asked about, you should, if the follow-ups are done, you should get a formal report. So, at that stage of that report we discussed a few minutes earlier, a biopsy may not have been done. Is that right?
So, based on the virus classification you get, if you are getting virus 2, if you are virus 3, you would come for another screening within 6 months. But virus 2, virus 1, mostly that means that's a normal or benign. So,
Doc, on behalf of my listeners again, you mentioned this classification. Can you just explain what it means? If you have any of these levels or degrees, what does it mean? And what is the Barrett 1, 2, 3 that you're mentioning?
All right. Okay. So anybody that comes for a mammogram, there are some things we are looking out for. So the radiologist will write a formal report looking at whatever they saw. So if it is viral, it means the imaging wasn't complete. So most of the time, they will let you follow up with an ultrasound.
Okay.
Then if it's viral,
you indicated that is what? Viral 0.
1.
You started with 0, or?
Yes. 0 means the imaging wasn't complete.
Okay.
So you need something to follow up with it, just to conclude on whatever is going on. So mostly we do a follow-up ultrasound after you've done the program, just to get whatever is good.
Okay. So then if it's higher than the 0, if you get into the ranges of 1 and 2, then...
So with 1, it's negative. They didn't see anything at all. Then with 2, they were benign. Benign means non-cancerous findings.
Okay.
So that one too, we let you come for your annual follow-up. Then 3 is probably benign. So we are not sure. So that's
Okay.
when we tell you to come for another screening 6 months.
Okay. Right. So
Then 4.
okay.
So 4 is highly suspicious of malignancy. So most of the time, when I get 4, a biopsy has to be done.
Okay. Now, let me ask you, though you've clarified, I understand. Let's just make sure. So, for my listeners, these classifications you're mentioning 0, 1, 2, 3, 4 are indicating whether whatever was found is cancerous or not. Am I right?
Exactly.
Okay. So, they are not indicating stages of cancer.
No, please.
Right. Okay. So you're getting this feedback after a mammogram that may be indicative, and the degree of indication will suggest what follow-up is needed and whether you need to do an ultrasound and so on and so forth.
Exactly.
Okay. So these numbers you are mentioning at this stage are not in direct reference to a diagnosis of cancer.
No.
Okay. All right, listeners, I'm doing the prosecution of the witness, Dr. Dr. Anita Uswefrie. We're trying to make sure that we've left no stone unturned. Of course, education and service provision continues after October, but we want to make sure we've done a tidy up with you. So the phone line is active 030-221-6541. WhatsApp is 055 11 11 997. Sena Milashibi wants to know how often you should have a mammogram. I guess he's listening to these classifications and asking that as a follow-up. If there's nothing, if you are clear, how often, Doc, should you have a mammogram?
So if what you recommend,
We lost you briefly there, Doc. If what?
if you are clear,
Yeah.
we recommend yearly.
Yearly mammogram.
Yes, please.
Okay. Right. Is that a universal recommendation? Does age come in here?
All right. So usually we recommend that you go through it yearly, but after around age 50, some decide that okay, you do it 2 to 3 years. Yes, if the previous ones were fine. But
Right.
most of the time, I tell people to do it yearly because I've seen people that they make the care of mammogram and the following day something was dead.
Okay. Right. So yearly or annual mammograms are recommended. Past the age of 50, you may have that spaced out a bit on condition that your previous mammograms were clear. Doc is emphasizing that some people miss their mammogram, and then when they come back to compliance, when they actually go and do one, something may be found. So the annual recommendation should answer you, Senam in Lashibi. Dede in Maryland asks, what about women who have gone past their menstruation gimmicks? They are menopausal. This is reference to the painful mammogram and your indication that it should be a week or so after your period. Therefore, what is the best time for menopausal women to do their mammogram? That's from Dede.
Okay. So usually, because the breast is pressed against plate, there's the image.
Okay.
There's a little discomfort, but it shouldn't be too much painful. Yes. So if the day is really worried about the pain, usually people do MRI, but MRI is expensive, and the fact that you're even confined in something that people who are claustrophobic, they don't like us.
Okay.
Area.
Right.
So MRI is there, but most of the time we are looking at the cost and the claustrophobic part. So MRI is there.
Right. Great stuff. 48 minutes past the hour of 2. We're running out of time. Doc, for those who have conclusive diagnosis and have commenced treatments, are there any key things? For example, okay, I have received a conclusive diagnosis. What should I be asking my doctor? Are there key things that you would recommend a woman who has had a conclusive diagnosis? Of course, some education would have been given alongside the confirmed diagnosis. But what questions should I be asking my doctor or my team?
So when you say conclusive diagnosis, like you concluded a person has a cancer,
right,
or doesn't have cancer, is that it?
Yes, I'm dealing with those who have the cancer. Or,
all right.
Yes, right.
So usually, immediately that confirmation comes, the next step will start your management with you.
Okay.
So with the management, it's, as I said, multidisciplinary. So the surgeon is involved, the oncologist is involved, the pharmacist is involved. You have the psychologist, the dietitian. So we let you, based on the of it, if you have the surgeon, we discuss that with, if the oncologist has to give you some medication, the chemotherapy, just to reduce the size of it,
okay,
before you go to the surgery, we discuss that with you as well. But anytime you see that you are not handling it well, we involve the psychologist before we go ahead with everything.
Right. Doc, am I allowed to request, let's say, a second opinion? Okay, you've done your business, you've got a diagnosis. As a patient, as the woman who's been so diagnosed, is it okay to opt for a second opinion?
Yes, please. We have friends who come to our facility later. They want to. You are allowed that. You are allowed that. Even if you want time for yourself to decide when you want to start the treatment, we allow patients to go through.
Okay.
So second opinion is allowed.
Right. Okay. And if I'm preparing myself for any of the treatment modalities, are there anything I need to do as I prepare to commence treatment?
So usually, if we are going with the surgery starts with you based on the state, whether you prefer a breast conservation surgery to be done, or you benefit from mastectomy, that's removal of the total removal of the breast.
Okay.
So the surgeon has to start discussing. But in case you have to get chemotherapy before, for that one, have some investigations to do. So we check your kidneys, we check your liver, we check your blood flow and other parameters in the blood. Then we also even do a chest X-ray and an abdominal scan, just to make sure the cancer hasn't gone to other organs like your liver or your lung. Then if everything seems to be clear, then we start checking. Based on the type of the chemo we are giving you, some of them will have to even check the state of your heart before we go ahead and start chemotherapy.
Okay. Right. So I will be giving information about all these different modalities and the requirements, especially on my part as a patient.
Exactly.
Right. Now, when it comes to the cost of these treatments, right? We've talked about the treatments and how they work or what they are supposed to do. You've told us that sometimes we're doing chemo with the strict objective to reduce the size of the growth or the tumor, etc., etc. All these are explained. But when it comes to payment for treatment, how is this handled? Are you just giving in quotes, let me just use the word invoice, and you're supposed to cough up the money and then we start? How is it done? Is there any flexibility in there?
All right. So some of the chemotherapies are covered by national health insurance.
Okay.
So those that are covered, it's part of your treatment. We let you. Those that are not, we let you know the cost. So mostly they come for every 3. So we let you know the cost per session. Every side the amount involved. Then you plan. So as you know that, okay, I have to pay this for this person.
Okay.
Some patients would prefer a total of everything just to have a fair idea the amount you are going to spend if you are going to have a 4 cycle or 6 chemo. But mostly I tell patients just break it down. Know that okay, when you are coming to bring this money.
Right.
It makes it easier.
Break it down, it's less frightening, less daunting, and less distressing.
Than to write the whole thing for you. That's when most patients are allowed.
Okay. Yes. Right. Good afternoon, Nortey. Please, can I just walk into a facility and request for a scan, mammogram, etc., or do I need a referral or a doctor's request? This is from Matthew in Osu.
All right. So for IMA, like this, you can walk to the radiology department, then tell them you want to do a mammogram or a scan. So based on your age, if you are 40 and above, even if you come and you say you want to do a scan, they know that 40 years and above, you are supposed to do a mammogram. So they will correct you that ideally you are supposed to do a mammogram.
Okay.
Then they do it for you. If it's a scan below 40, they will do it.
Okay.
So I don't think you will have to get a prescription. Yeah.
Okay. So you can walk in and make the request. Okay. Now, if I don't have all the money, will you, the clinicians managing my cancer, will you start? Or would you want me to have a certain threshold amount of money? Okay, it's been diagnosed. This is the treatment plan. It's been discussed. But I have a little. Would it commence?
So it depends. People have therapy. We tell the exact cost involved and the number of times will be coming. So most of the patients, from what I've seen, they make a deposit, maybe half of the money.
Okay.
And as they are coming daily, they start preparing to pay the remaining. So it's not like you have to get everything. For chemo like this, for the session you're coming for, you have to pay for it. But it doesn't mean you have to pay for the entire session before you get your no. But most of the time, I tell patients that to avoid any break in your treatment, as we've told you the amount, try and prepare so that it won't get to a point that today you have to come for chemo, then you don't have them. Some will wait weeks later, they still have that. They didn't have them. They've now got them.
Right. Okay. So we don't want your treatment to break. We want to have a continuous flow of treatments in order to achieve the treatment plan goals. That's right. Yep. Okay. So I was going to ask, you mentioned psychologists coming into the picture. Obviously, they are managing the psychological response to all of this enormity of a diagnosis. Do you have any bridges with support and care groups? I'm undergoing therapy. I'm not aware of any support group. This week, actually, we had intended to speak to survivors and the support angle of this. We'll try and do that next week. But does the hospital itself facilitate and promote the bridges between support groups and patients?
All right. So there are some support groups around. Just that, in Ghana, because of the stigma, most people don't want their check out. As I'm going to breast cancer, or I'm going to breast cancer, as compared to what we see in the Western side. People are mostly out there confident about their treatment. They survive breast cancer treatment. It's not like that here.
Okay.
So the support groups are actually seen. Sometimes we try to engage them, but you find that the patient is not even willing to be involved.
Right.
So that's the challenge we mostly get here.
Okay.
Unless they know the support group is going to actively pay for their treatment.
Okay. They are more biased towards financial support.
Exactly.
Right. But the emotional and other forms of support, right?
Because of the stigma, most people don't want to get comes to that.
Right. Linda wants to know how much do mammograms typically cost? So
mostly it's around 400 to 500. Because of the Pink October, a lot of facilities use their own. IMA was even giving 40% discount, so people were paying about 200 and something. But she should budget around 450, maybe 500 maximum.
Right. 500 maximum for a mammogram. Okay. This is from Dede in Maryland again. Is it true or is it a myth that if one's dad had prostate cancer, there's the likelihood that his daughters may have breast cancer? This is from Dede.
All right. So I spoke about BRCA gene mutation, if you remember, the non-modifiable risk factor. Yes. So there are some cancers that are also related to BRCA gene mutation.
Okay.
We have breast cancer, we have ovarian cancer, we have prostate cancer, we have colon. So if there's someone in the family that has had ovarian cancer or prostate cancer, it could be the person has a mutation,
right?
And we don't know. So that's why it puts you, the female, at risk,
right,
of the breast cancer, or ovarian cancer.
Right.
So
that is related to the specific genes involved.
Yeah.
Okay. And if you have them, then there could be that relationship or that linkage or correlation. Yeah. Okay. Right. Great stuff, Doc. We've run out of time. You've been most helpful. I want to cautiously assume that we've cleaned the slate and done, should I say, the best education we could have done for the month of October. But we will not hesitate to pull you out of your Sunday slumber, so to speak, with the permission of your husband and your facility, of course. We're most grateful for this education, and we'll look forward to sharing some snippets of the data that seems to indicate a positive response this year, so that we can give women and listeners a sense of what we've been able to achieve together in partnership with them.
That's our. We work on that. We let the public also.
Right. Okay. Many thanks once again, Dr. Anita Osufriye. She's the resident oncologist at the International Maritime Hospital in Tema. They've partnered with us so generously over the Pink October month, and she's been here with us on our post-showdown wrap-up show on breast cancer. If you have any questions, concerns, you can always find IMA and many of the other facilities online. And breast cancer education, screening, awareness, treatment, management continues post